So today we have Dr. Michael Marks here with us from Boston Scientific. He's a senior medical director at Boston Scientific, specifically over the Intercept division. He is a orthopedic spine surgeon also has his MBA from UT. So again, welcome to the show. We're excited to have you here.
Happy to be here.
So first off, obviously, your background's really impressive with both an orthopedic spine surgeon and as an MBA from a great school. But what really got you involved with Boston Scientific and specifically with the Intercept procedure?
So I was actually contacted in 2016 from some principals that were with Relievant at the time, which was the company that was founded in 2006 for the Intercept procedure. It was actually a spin-off from Johnson & Johnson. And they were in Washington, D.C. To defend their FDA request for clearance. And the chairman of the board there was somebody I had known in a prior life. And he says, I think you're going to kind of be interested in this. It's really revolutionary. So I met him in D.C. and I got there and I said, this is really exciting. What do you do? And he said, well, we've developed a technique to ablate the basivertebral nerve. I said, wait a second, a nerve inside the bone? I said, when I was in medical school, we were told that there are no nerves inside bones. They're only on the outside of bones in periosteum. He goes, no. This was discovered in 1998 by Antonacci and Hagenes at Baylor University. And I go, well, I finished medical school in 1982. I must have, where was this published? He goes, oh, it was published in the Journal of Spinal Disorders. I go, yeah, I don't subscribe to that. So it's obvious how I missed this. So he explained to me all of that. They were there. And then about a year later in 2017, he calls me up and he goes, well, we got our FDA clearance and we're moving ahead. We still have some clinical studies to do. We're going to do some commercialization. Would you do some consulting work for us? You've got some expertise in coding and reimbursement. We've got to figure out how that's going to fit into all of this. And I said, I'm happy to. And I said, so I know about the nerve. I said, how do you identify the patients that would benefit from this? He says, well, it's really interesting. It's a biomarker seen on MRIs called modic changes.
Yeah.
And so I start chuckling and he goes, what's so funny about that? And I said, well, I did my spine fellowship at the Cleveland Clinic, 1987, 1988. And that fall during an interdisciplinary rounds conference, the radiologists were presenting. And whereas I know it's hard to believe nowadays, but where there's an MRI on almost every corner, but back then in the mid to late 80s, hospitals had MRIs coming to them in trailers.
Yeah.
One day a week. Well, the Cleveland Clinic already had 2 permanent magnets in place. And I jokingly say that they probably offered free MRIs to all 700,000 people in Cleveland to see what does this anatomy look like. And so they had done a whole bunch of spines. And the neuroradiologist throws up sheets and sheets of film because this was before we were digital. And he asks the group, so what do you see here? And we go, Mike, what do you want us to see? He goes, well, there were these bright spots and dark spots here. And he goes, yeah. He goes, I'm calling them modic changes. And the head of the division says, great, Mike, you've named something after yourself. What's the clinical significance? And he goes, I have no idea, but somebody's going to find out someday. So for me, coming here is full circle. Being there when modic changes were first described. 11 years later, you have the basivertebral nerve. And the reason that I had my transition professionally, because I was practicing orthopedic surgeon, spine surgeon, then became a hospital administrator, then consulting work, was because I had chronic low back pain. And I could no longer stand in the operating room, especially wearing lead 8 hours a day. I had chronic back pain. I basically came home and laid out on a couch 2 to 3 days a week after being in the operating room. So it was really awful. And back in about 2010, I sent my MRI to about 7 colleagues, and I got back 5 different opinions of what should be done.
I think that's one of the things that's most frustrating for patients in general is exactly that experience. Like, what do they do? So, sorry, continue your story.
No.
We'll get into that.
Because you're exactly right. It becomes a challenge because the back really is a black box, because many people want to look at MRIs and say, oh, that's the problem, that needs to be fixed. But we know from actually many studies at this point that MRIs are highly sensitive and not specific. So it shows pathology that's not causing the patient's problem.
So, for example, you can have a disc herniation and it's not causing you any pain at all, or you can have a disc herniation that is causing you pain. The MRI will tell you the presence of a disc herniation, but not if it's causing you the pain. Correct?
Yeah. And so that really gets to the issue of that appropriate care of patients is taking a good history, performing a good clinical exam, coming up with a presumed diagnosis of what's most likely happening, and then using the MRI to corroborate what exactly is the problem and what's the best way to address it. But interestingly enough, if you've got the presence of modic changes and axial low back pain, it has a specificity of greater than 90%.
Wow.
So therefore, it may not be responsible for all the problem that the patient's having, but it is actually the best radiographic marker to at least identify and potentially treat and eliminate one potential cause of back pain, because as we know, the challenges with back pain is it's very frequently multifactorial.
Yep, absolutely. Well, and I think let's dive into that for a moment. So I think when people go and get a second opinion and they hear something else, they assume that the first doctor was wrong. But that's not necessarily the case. There are multiple causal factors for back pain. And it may be that one doctor's really focused on one and another doctor's focused on another, and it could be both of them. It might not be one or the other. So, you look at this and say, why do we do MRI? With the data that you said, a lot of people would say, well, why do I need an MRI? And I think that in reality, people don't realize that we did procedures for a long time without MRI. MRI is not necessary for a lot of things, but this is my belief of why we do it. So one, let's say a patient comes in and they have radicular pain going down their leg. We do a good history. We hear all about this. We do some orthopedic tests, whether that's a Kemp's or a straight leg razor or something like that. And we know that this is discogenic. We know that this is, before seeing an MRI, we have a very good idea that, this is probably a herniated disc that's causing it. So why do you get the MRI? And with most of the doctors that I talk to, most would agree that the MRI is not necessary to diagnose the disc because we already did that. But what is there is insurance oftentimes requires it because there are other things that could be there. And we want to rule out the rare things, the cancers and the tumors and some of those things that could also present this way. And oftentimes that's one of the reasons. Is there another reason that you believe that we take MRI besides just confirmatory, not necessarily diagnostic, but confirmatory findings?
Well, I think it's confirmatory. And if you do need to have something done from an interventional standpoint, from a surgical standpoint, it is the final roadmap. But to your point of, do we need MRIs all the time? So my first personal experience with the world of spine surgery, I was a third-year medical student. This was back in the early 1980s. And CAT scans had just come into being at the time. So I was actually admitted to the hospital on a Monday to have a myelogram performed. Then kept flat in bed on Tuesday so I wouldn't have a spinal fluid leak and get a headache. And then finally had my surgery done on Wednesday. But when the surgery was done, I wound up having a 6 or 8 inch incision in my back because standard of care at that point was not getting an intraoperative x-ray to localize where you were. That was just not the standard of care.
Wow.
You found the sacrum and then you counted the levels up from that area, and you actually took a tool and you would hit the sacrum as a sounding board to understand where the anatomy was. And so one of the challenges back then, and we kind of look at it as that was the Christopher Columbus days of surgery, because like Christopher Columbus, he set off really not sure where he was going. When he got there, wasn't really sure what he had found. And when he came back, he really wasn't sure what he could describe to everybody. And that's that's kind of really what spine surgery was back in the 80s. And then when CAT scans got refined pictures, my first CAT scan looks like a Rorschach test. It's just a lot of black spotches and stuff like that, not great definity. And so imaging really has helped us a great deal.
And it's progressed, as you just said, massively. The images we can get now are so much more detailed than before, but please continue.
Yeah, and so the issue is, from the history, and the description of where a patient's pain is or the weakness that they have, you should be able to say, oh, this patient should be having pathology affecting the L5 nerve root.
Yep.
And so when you get the MRI, if you don't find pathology back there to explain the L5 nerve root symptoms, do not operate upon that patient for L5 nerve root. If it turns out that it shows a herniation at L2-3, operating upon that herniation is not going to address their problems.
Yep.
And so that's really where, as surgeons, as clinicians who are treating patients, you need to put all of that together. And in fact, one of the first persons to do this in the world of spine was Dick Rothman, who was in Philadelphia, and he created Venn diagrams. Those circles that we all talk about, and overlapping circles. And basically, what they were able to show is that if you had the history, physical, and imaging all correlate together, you had a greater than 90% chance of success of it.
Yep.
And I think that, unfortunately, we have forgotten a lot of that basic science and a lot of that statistics, where the worst outcomes come when these Venn circles don't overlap each other, and then we have poor outcomes, and then we have very frustrated patients.
Yeah, I think that one of the miracles of medicine today is our technology, but to your point, we can rely on it too much, right? So clinical, listening to your patient and hearing their story and understanding what they're saying and how that now correlates with my clinical finding and what we're finding. Hey, this dermatome is like this myotome. These are the issues that we're seeing. We correlate those together, and then we say imaging on there. And from a type of care perspective, you'd also be looking at what's the research show and everything like that. And when you can get all those to overlap, that's when we're going to see those great outcomes. But I do believe that with the advancements of technology, because it can do so much, it's really easy to say, I'm going to put less importance on maybe what the patient says and more importance on what the imaging says. And I think you're absolutely right. If anybody that does that is going to make a mistake in the fact that it's not one or the other, it's where do they both overlap, because that's where we're going to have the greatest impact with our patients. And
there's no question. And in fact, the American Academy of Orthopedic Surgeons did a survey of surgeons and also of our patients back in 98, 99. And the conclusion of that survey was that orthopedic surgeons, and it can probably apply to other specialties too, were high tech and low touch. And so the Orthopedic Academy at that point went on to develop in conjunction with the Institute for Healthcare Communications, a communications workshop classes to help physicians improve their communication skills. And the biggest thing that generally is lacking is empathy. Empathy basically says, I hear you, I see you, I understand what you're going through. And if we depend too much on the radiologic images, which is, as somebody at Boston Scientific now, working on trying to get prior authorizations for patients, that's really part of the frustrating aspect, because we very frequently run into the medical directors of insurance companies who want to base the entire diagnosis on the MRI film, even though that's not where the money is to make the ultimate diagnostic decision.
Yeah, I think that in healthcare, my belief would be that anything that's high tech and low touch, you're going to have poor outcomes. But in part, because patients aren't going to believe you care. They're going to feel like a number, and when they feel like a number, we're going to see decreased compliance. We're going to see that patients aren't going to get as good of outcomes. I believe when a patient understands the care that you're recommending and why and how it could help them, they're much more likely to get the needed care, and with that needed care, they're going to get good results. Versus a patient just saying, well, the doctor knows best, we'll just go for it, even though he didn't explain it, I'll just go ahead. I think that a real big focus needs to happen across healthcare, where we still are listening to our patients and using that to be empathetic and direct care. And I think the challenge is what you just said, which is how do we make sure that we can turn that into good data for insurance companies so they can say, you're making a real impact here, and it's not only radiologic findings, but it's actually, there are some subjective and even objective findings that can come from the patient that are also important in identifying these. And if we can figure that out, I think we can improve in some ways the insurance healthcare dynamic.
I think you're absolutely correct. And in fact, what we've definitely need to do is change from the paternalistic aspect of medicine, where the doctor is all knowing and everything, move to shared decision making.
Absolutely.
Answer that question, why?
Yep.
Why are we doing this? I know, if we all have children, we get bothered all the time.
Most common question from kids.
Why, daddy? Why, daddy? Why, daddy? But that's a really important question in order to be able to address. And to your point of doing the studies and going through, we've been able to, at Relievant Boston Scientific, we've actually had 2 health economic papers that help demonstrate the actual quality of life, but also the financial benefits of the Intracept procedure, because unlike all other ablation procedures that are performed, the basivertebral nerve, getting back to that nerve again, very unique, is the only peripheral spinal nerve that's mostly unmyelinated, meaning it doesn't have a covering over it. So it truly is a one and done procedure. And so you have permanently addressed the basivertebral nerve as being an etiology or causative factor for the pain. Whereas if you're doing SI joint ablations or facet ablations, we know those nerves are myelinated, so that within 6, 12, or 18 months, there's a good chance you're coming back and you're repeating the procedure again.
So let's. So obviously, talking through this, you're a spine expert in multiple different ways, both as a surgeon, as a consultant, on so many levels. So for people that have never heard of the Intercept, maybe we go into a little bit of depth of what is the Intercept procedure, and then we'll go into kind of who's it for. So what is it specifically?
So it is. So it turns out that when patients develop degenerative disc disease, either through trauma or age, we wind up with microfractures and fissures at the end plates, which are the top or bottom portion of the vertebral body. And that permits the jelly of the donut, the nucleus pulposa, to actually leak into the vertebral body. The nucleus pulposa likes its own environment. But when it comes in contact with the bone marrow, it releases all of these inflammatory mediators. And those inflammatory mediators are what irritates the basivertebral nerve. And those inflammatory mediators wind up creating the visual findings that we see on the MRI. With the modic changes. So it's really a very, very nice correlation. And what we know is, when Modic first described these changes, he was for the most part looking at mid-sagittal cuts. He was looking at what we began to call the hamburger sign, thick. But what we have seen from our clinical studies and done regression analysis is that Modic is binary, or the degenerative end plate changes are binary. You can have a little bit of Modic or a lot of Modic. Those patients can have an equal amount of pain. And so it's one or the other. So with that being identified, what we were able to do is develop a series of tools and instruments to go down a portion of the vertebrae called the pedicle, to get into the vertebral body in the location where the basivertebral nerve is. And then with a probe connected to a generator, we're able to heat that nerve up to 75, 85 degrees to then destroy it. As I described it to one of my colleagues who's a dentist, he goes, "You guys are always copying what we do. You took methyl methacrylate and started using that in joints and in vertebral bodies for vertebral augmentation. You guys are doing nothing but root canals in people's backs." And again, it's very simplified, maybe a little bit too crude, but that's what we're doing. We're eliminating the pain generation and the cause of that pain.
So let me see if I can summarize kind of what you said here. So as we age, we begin to see degeneration within the spinal column, and that's going to result in axial spine pain, right? So they have really centralized pain. It's non-radiating, doesn't travel down into their legs or arms or anything like that. And with that pain, the way that it's treated classically is going to be medial branch blocks and radicular and RFAs, right? So RFAs and MBBs are how we're traditionally treating that, but you have to get them every 6 months to a year, and frequently, it may give you 3 years at first, and then 2 years, and then 1 year, and then 6 months, and that's what you're talking about of those nerves. Even though you do an ablation, they grow back and that's why the pain comes back, is because they're going back. Well, unlike targeting those nerves, where we're really targeting the medial branch, this is instead right at the disc. So you have in your spine, you've got all of these vertebral bones, and in between you've got the disc. So you're saying you get some cracks in the tops and bottom, some of the disc product leaks into that, and it really irritates and inflames the basivertebral nerve, which is the nerve that goes along that spine. If you irritate it, it's now causing pain, and that's where you're saying we can take an approach just like a root canal where the nerve is really inflamed. We can go and we can actually solve that nerve problem by, in this form, ablating the nerve that's causing the pain, and then in doing that, the person has relief. Is that correct?
That's a great simplification of it. It makes it really straightforward. And the thing to, again, recognize is that the cause of back pain, as we were talking about before, can be multifactorial.
Yeah.
And so you may have facet disease. You may have maybe some pain from some spinal stenosis or disc herniation, but those things generally will cause radicular pain going down the leg. So again, getting back to what we started about before, taking good history and physical examination and truly understanding, but knowing that the pain that you're seeing somebody complain of is you're trying to treat the predominant problem. Early in my career, I was explained Sutton's Law. Sutton's Law comes from the bank robber Willie Sutton. From the Chicago 1930s, he finally gets captured, and they say to him, "So Willie, why do you rob banks?" And he goes, "Because that's where the money is." And so one of the things that we encourage physicians to do, and we've got a form to help them with a patient intake form, is that if a patient's complaining of 90% leg pain and 10% back pain, and they've got modic changes, the Intercept procedure is not the procedure for them, because that's not where the money is. You're not going to have a happy patient if you only solve 10% of their problem. But if they've got 90% back pain and 10% leg pain, again, that multifactorial, focus upon what are the etiologies and what can be caused there. So again, I'm a big fan of Sutton's Law because, again, that's where the money is.
And when you're talking about money, obviously, we're not talking about where the reimbursement is. We're talking about that's going to be what's valuable, the money, what's valuable to the patient. Right?
Exactly.
And so we want to always go after the patients coming in, and this does happen, unfortunately. Patient comes in and says, I've got massive amount of pain in my back and down my legs, but it's mostly in my legs. And it's like, oh, well, we're going to focus really on your back. And it's like, well, but the pain's in my legs. And so now pain in your legs can come from your back, and that happens actually very frequently. However, we need to be able to either connect the dots if it is really a disc issue and we're treating the back for the legs. We need to be able to explain what you said before, which is why. If we don't explain why, patient's going to go like, they just talked about my back the whole time and I have pain in my legs. Well, that's okay. It could be your back. But I love kind of that Sutton's Law, which is whatever's valuable to the patient, what they're coming from, that has to be addressed. Whether it's explaining and connecting the dots or it's actually based on procedurally, we need to make sure we're addressing that thing that's most valuable to the patient. And when we do that, you have happy patients. And when you have happy patients, they're going to get better and they're going to continue to improve. And that's how we change our community. Right. So I really like that. I want to kind of rewind for a moment on this. So the other thing that you were talking about is with this procedure is who really is best for this. So that axial spine pain. So maybe let's talk a little bit more about how this presents with patients, because I know that people listening to this, they're not going to necessarily know what axial spine pain and everything. So how do these patients present in clinic?
Yeah, so these are patients that very, very frequently have been described by a doctor as they've got restless spine syndrome. The medical assistant or nurse brings a patient to an exam room and says, please take a seat over here. The doctor will be in to see you shortly. Doctor shows up about 5 minutes later, and the patient is not sitting in the chair. The patient's standing up and they're leaning against the wall. Why? Because they just don't feel comfortable staying in any one position for any period of time. And so what they find is that over time, there are a lot of things that are uncomfortable for them to do. They don't like long car rides because you're stuck in one position for a period of time. They don't like going to cocktail parties and social events because you've got to sort of stand in one spot. And you'll notice the person who's leaning up against the wall, they've probably got something going on in their back, just like when my children were little and we'd go to the supermarket, I'd point out to my three daughters, and when they were little, I'd point out what I thought the orthopedic problems were for these people.
Shopping cart
sign, exactly.
Claudication.
Right. But you've got somebody who's about 70 years old who's leaning on a shopping cart, and all they've got is a quart of milk in their basket. And so again, you ask these people, what activities aren't you doing anymore?
Yeah.
Oh, I gave up gardening. I don't do anything truly recreational. I've bought 3 or 4 different mattresses over the last 10 years because I just can't get a comfortable night's sleep. And for me, as we began to talk about before, this is all really personal. I said it, I was a spine surgeon, a hospital administrator, consultant. And the reason I went on that journey was because I had chronic low back pain. And after working with Relievant, I went back and looked at my own MRIs. And it turned out I had modic changes. So I had vertebrogenic pain, which is how we describe this from a diagnostic standpoint. And in fact, so much so that the CDC in 2021 gave vertebrogenic pain its own diagnosis code. So if you've got vertebrogenic pain, one of the procedures that's indicated for you is the Intracept procedure. But in 2010, my wife and I were remodeling a kitchen, and my wife turned to me and said, "I married you for better or worse. I did not marry you to always be the one to load and unload the dishwasher." So we built our dishwasher 12 inches off the ground so that I could bend as much. So I did not have to bend, and I could put the dishes away. So again, to the point that we were talking about before, talk to the patient, listen to the patient. You'll know that you've got somebody, and very frequently it's been called, patients have what's called anterior column spine pain. Yeah. But I'm not a firm believer that is the gospel, because, as I like to say, not every patient's back read the book.
Yeah, I like that.
We've got a pain doc in Utah who had mostly pain with extension. His partner did medial branch blocks on him twice. He didn't get any relief, and his partner said to him, "You've got modic changes. We should do the Intercept procedure." He goes, "But I've got more pain with extension than flexion." And he says, "But nothing has worked to try and get rid of that pain." So they went ahead and did, and he got 95% relief of his pain. And so again, back to my story, in September of 2021, I had the Intercept procedure done on me at L4, L5, and S1. And it solved 99% of my back pain. I no longer have that chronic low back pain. I sleep through the night. I've given up having to buy different mattresses to see, what's needed. I no longer need an elevated dishwasher to be able to load the dishwasher. I can get on the ground and play with my grandkids. I used to always just sort of stand up and look around, because if I got down, it was really hard to get back up. It was really uncomfortable. So again, getting back to your question, it's the patient who goes, "God, it hurts with this, it hurts with that. I really can't get comfortable." You're going to have a sneaking suspicion, because they all sort of sound the same.
It's those patients that are I love what you said, that restless spine syndrome. So again, this is true back pain, right? Oftentimes that's what they'll associate it. It's this. They're not saying it's in their legs, their arms. Like this is focal back pain. They don't want to sit. They don't want to stand for a long time. Don't want to sit for a long time. Being active is a little bit more comfortable, but not getting down on the floor, not getting up. So those patients that are experiencing that, they can't garden anymore. They don't like to go to the movies with their friends anymore, anything like that. Good chance that they may have some, like a true vertebrogenic pain. And if it is true vertebrogenic pain, obviously the Intercept could be a great procedure for them.
It can be. But the thing also to remember, and I think it's always important to touch upon it, is that before we get to procedures, there are, the traditional things to do, whether it be physical therapy or chiropractic care and medications. I'm a firm believer that core stabilization exercises are really, really important. Huge.
So with the Intercept procedure and what we're talking about, you've been, obviously you were a surgeon, consultant, and now, you work with Boston Scientific as their senior medical director. What's some of the data and results you're seeing with patients that actually get this procedure?
So I always like to start with our clinical studies, because that to me is the gold standard. And all of our clinical studies, we've had 5-year follow-up of those patients. And what we know is a third of them actually say they're pain-free 5 years out. A third say they're somewhere between 50 and 99%. And a third say that they're up to 50% improved.
Wow.
I think what's important to remember in that last group, and we earlier talked about the specificity of modic changes, about 90%. So it's not 100%. There are some false positives. And that kind of went along with our clinical studies. About 10% of patients who you thought were ideal candidates didn't get relief. So I think that that's really an important part of informed consent, to talk to patients so that they don't think that the doctor they went to was some, wacko, and God, he promised me. And so, we always like to say, under promise and over deliver, which I think is very, very important.
Good practice in healthcare.
But that's really, what the clinical studies say. What we've seen in commercialization with almost 60,000 patients now being done is kind of along the same lines, which, again, having been involved in healthcare for 40 years, it's kind of unusual to see commercialization of a product follow along what the research found. And part of it is, I think, we've really put the focus upon making sure the correct patient is being done. The Intracept procedure is not a Hail Mary. It's not a cure-all. Stick to what the indications are, and you're going to have great results and really happy patients. But the other aspect that's really important here is solving vertebrogenic pain sort of was the holy grail. It was the unsolvable problem.
For a long time.
Yeah. I mean, the last time that I actually fused somebody's back with pure axial low back pain was 1995. It's hard to believe, 30 years ago, because the results were so terrible. I was having like a 25% success rate.
And I think a lot of people don't realize that. Like, what you just said is so important. I want to actually reemphasize. Any type of procedure, there's a chance of you still having pain afterwards. People think like, oh, I'm going to get spine surgery and this is going to solve it. But the data, even going back in time on spine surgery, it's the better you do at getting that Venn diagram we talked about, the more likely the outcomes. But I mean, I think I was reading a research article yesterday that said it's still up to 40% of people still have back pain after surgery. Now, it can be less than that, but it's up to 40% of people have back pain still after surgery. And so what I love about what you're saying is part of that is because there's other things that are causing it. And the Intercept is one of those things that may be a better option for certain patients that have vertebrogenic pain than going in and fusing it. And so, again, as you're looking at that, the better the technology gets, the new and less invasive options we have for treating what we used to treat in a different way, we can now treat this way. And you're seeing that in the research.
Right. And to your point is, when we first presented this in the North American Spine Society meeting, there was a physician there who'd done a lot of total disc replacements. And he said he had about 20 to 30% of patients following total disc replacements. Their radicular pain kind of went away, but they were still, having back pain.
Axial spine pain.
And he went back and he looked and he goes, damn it, those patients had modic changes. They had vertebrogenic pain. And so it's the same thing, I think, if you've got somebody who's got some spinal instability where they definitely need to have a fusion performed, if they've got modic changes, the fusion's probably not going to solve that portion of the pain. So again, we've got to take a multidimensional approach to addressing patients' low back pain. And it's where we spend a lot of time trying to educate insurers, because ultimately, at the end of the day, trying to get a patient to the operating room table is mother may I.
Yeah. It's not the doctor's fault. It's very much we're dependent on insurance, proving to insurance that they need it.
Right. And that really has been, sort of one of our challenges. I mean, for new technology and having been involved in this for a long time, 2 level 1 studies, a clinical trial, more than 42 papers that have been published in peer review literature about the Intercept procedure. We've got great science. In a short amount of time, we were able to get a level 1 code. We got to the CDC to give us our own ICD-10 code. Currently, we've got over 160 million covered lives from insurance companies. But until we get to 330 million, until we become universal, and that's really part of the challenge that we have, is because this has only been commercially available for 6 years, and in the middle of that we had COVID, which really sort of slowed us down a little bit with momentum. But still, if patients need spine surgery or if they need joint replacements, there are still some challenges with insurance companies on getting
And
coverage.
that's been around forever.
And they've been around for forever. We've been doing joint replacement in this country since the early 1970s.
Wow.
So it's been almost 50 years that joint replacement's been around, and we still get pushback from insurance companies on some patients and stuff. So I'm really pleased at where in a short amount of time we've been coming. But
I don't think you get that unless you're getting good results, though. Right? Like, I think that the whole point of the healthcare system is it's really hard to get new surgeries and new procedures and new technology into practice. And in part, it's because, the FDA and all of the associated bodies are trying to make sure, is this a proven technology? First do no harm is the oath
is it safe?
Of medical, the medical profession. And so there is this big hurdle to cross. But the fact that Intercept's done it so fast, I think, is a testament of really good data, really good research, and really good outcomes, because you don't get there quickly with all of those things aligning.
And that's where early on, we reached out to the thought leaders to get them on board. We're now working on our 4th generation of instruments because we've done something well. We know that we can improve it and make things better. But the fact that we've got the North American Spine Society on board, the International Society for the Advancement of Spine Surgery, the Aspen writing their guidelines, IPSIS, the Pain Society, the fact that all of these have really come on board with positive policies or positive guidelines is because of the strong science. And that was one of the things that the leadership at Relievant said, is that we've got to do better than what previous technologies have done. And they spent close to $70 million on clinical studies. But
really investing heavily to make sure that it is a good product with a safety. I mean, patients don't want to be experimented on. They want something that's safe, that's going to work. And that's really what you're saying. They've made the investment and the outcomes are clear.
Right. And in fact, when we argue, so I've been involved in more than 1,800 administrative law judge hearings. Mm-hmm. Those are hearings for Medicare Advantage patients. If the Medicare Advantage company has denied it, you can appeal it to the Office of Medicare Hearings and Appeals. And it's a formal courtroom hearing. It's done telephonically. And my statement would be, as physicians, yeah, what kind of experiment on patients? But as a physician myself, I don't want any experimentation on me. And I said, the fact that I jumped in with both feet with this, I knew the science was there. I knew that it was safe. I knew that it was effective. And that was, in my mind, something really very important to do. But insurance companies, unfortunately, they don't have any great incentive to add new technology to the coverage, because, as one executive said, look, there's no technology out there that ultimately hasn't cost us more money, because there's just more stuff out there, to do. And I get that, but this was really a very unique problem with a very unique solution.
Yeah, I think it's a really interesting thing that you bring up, because you are the perfect person to advocate for this, being both a highly trained orthopedic surgeon and a patient. You actually got relief from this, so you can advocate in a way that is on both sides of the the spectrum for this. But when we look at this with insurance, like, insurance are for-profit companies, and a lot of patients think the insurance is on their side. And, insurance companies, I do believe, have really good intent. The reason that they're there is to try to make care accessible and to ensure those losses and everything like that. But in the end, there are people within the organizations that look at this and say, show me the data that it's going to save us money so that we can do this. And I think the way that we have to solve that is really in data, right? Because I believe that the best procedures that are coming out right now are going to show that immediate impact to the patient. But I think longitudinal studies where we're actually following these patients and saying, how are they more active? And because they're more active, what is that doing in the cost saving for the payers down the road? And I think that if we can do a better job of following these patients and showing the cost savings, we're going to see insurances saying, not only is this a good procedure, but we can pay for it because it's going to save us money. Not just because it's going to help the patient get relief, but it's going to do that and save us money. And when those combine, that's when we see mass adoption of insurance companies going forward with the procedure.
And that's why we're very proud of the fact that we've had these 2 health economic papers that are demonstrating this because
maybe share some insights on that. How is it saving insurance companies money with the economic studies you just said?
Well, because as I said before, the fact is that we know that this is a one and done procedure.
Okay.
We know from our clinical studies that 93% of patients at the area where the Intercept procedure was performed no longer had any other procedures performed in that area. So they're not getting facet blocks, they're not getting epidural blocks, they're not throwing
years
darts.
and years and years of MBBs and RFAs. So I mean that's a good thing. Like if you're a patient and you've been getting RFA after RFA after RFA, maybe ask to the doctor is there a better solution with the Intercept? And that's what you're saying is if we can solve this once and for all, it stops the throwing at darts trying to solve the pain, and that saves insurance companies money and patients time and pain. Right.
And along those lines, one of the first patients back in early 2019 when we had very little insurance coverage, there was a doc in the Midwest who said, hey, I've got a patient, he's been denied insurance, he's willing to pay cash for this. And we said, well, what's your suggestion? And I go, well, we don't have any data, you've got to decide. Well, he turned to the patient and goes, well, what do you think this is worth for you? So the patient said to him, Doc, I've been coming to you for years. I have a high deductible insurance that's $7,500 a year. I've paid you $15,000 the last 2 years. That's the only health care that I've done, and I still have pain. If you really think this is going to work, he goes, I'm willing to bet on you and on me. How about if I pay you $12,500 to do this operation?
Out of pocket
cash. He goes, that's this year and 3/4 of next year. And so he went ahead with the procedure, and the doctor told us that, when he was now 2 years out from his procedure, because he never saw him again, 2 years out from the procedure, he made up a fake check for $2,500 and wrote his name on the check. And he goes, I got paid $2,500 this year because I no longer needed any medical care.
That's awesome.
And so, to me, that sort of epitomizes, for these patients. But also, again, having been one of those patients, I gave you the statistics on, how much relief patients get. In our clinical studies, 67% of patients had pain for more than 5 years. When you start talking to these patients, because I was one of them, and you say, maybe I can get you 50% relief, Doc, I'll take anything you can give me.
Yeah, because you've just been suffering for years, and you've tried a lot of stuff.
Right, and I think that may be part of the fact that when you go ahead and do the Intercept procedure, and they get that 50% of relief, maybe they've still got a little bit of facet disease, a little bit of SI joint, but they go, you know what? It's not constant the way the vertebrogenic pain was. I'm good. I can live with this. I've got, a significant quality of life back.
Well, at Arizona Pain, and at Pain Doctor, one of the things that's really important for us, and we talk about this a lot, is multi-specialty care and treating the root cause. And we've touched on both of those today because, when you do the core stabilization, you do the physical therapy and the chiropractic stuff like that, that's going to produce a lot of long-term return to activities of daily living, because core stability, if you hurt your disc the first time because you had a weak core and you don't fix the core even though your pain's gone, it's going to come back. Right. So again, long-term benefits there, but we love how the Intercept fits into our profile of procedures we offer because of exactly what you said. When patients come in, one of the key things that we want to do is find the root cause of pain, not cover up the symptoms with opioids and pills and stuff like that, although there is a place for those. I don't want to demonize that. But we want to say pain is important, but what's causing it? And how do we fix that? And how do we make sure it doesn't come back? And so I love some of the stuff you're talking about with the Intercept as far as when we really have done a good job at finding these, this Venn diagram of, modic changes and clinical presentation and everything like that. We find that right patient. Usually this is a very long-term solution for vertebrogenic pain. Treat at the root cause. This specific pain doesn't come back unless there's re-injury and stuff like that, or different levels, I'm sure. But it's long-term relief. And I think that's what patients are looking for, is exactly that long-term relief. So we're really happy to do that. So I was going to ask you another question, though, really quick. One of the things that we ask on this show for every guest that comes on, every guest that comes on, even though this is unscripted, every guest that comes on, we ask the question, about the opioid epidemic. And it's specifically, we have 100,000 people dying from opioid-related issues. Now, we know that not all of those are from prescriptions. In fact, most of them aren't from prescription opioids, but the data shows that about 70 to 80% of those people started on a prescription opioid. And then they got into street drugs and everything like that, which ultimately led to their death. But again, as a medical profession, there is some responsibility on us of, in part, we created this issue, we need to solve this issue. And I think that one of our doctors said that. And I love that, and that's really stuck with me. We need to be an active part in solving this. So, in your opinion, from your experience and years of experience, what are some ways you feel like we can really help to defeat the opioid epidemic?
So I think the one statement that you made, which was so impactful, is that most people went on this opioid journey with a prescription that was begun by a physician. Mm-hmm. And I think, unfortunately, we were sold a bill of goods that these are not addicting if you have truly have pain, and that don't worry about it. And those, obviously, we now know are false.
Yep.
And I think a lot of the studies that have come out have shown. So again, I've given you some of my medical history, but between my Intracept procedure, a decompressive laminectomy for spinal stenosis, between a knee replacement, I treated my pain with ice, an anti-inflammatory, and Tylenol. That was it. Those are total knee replacement, big operation. I mean, when I think back on the amount of opioids that I originally gave to patients back in the 90s and early 2000s, because
that was standard of care.
That was standard of care. That's what you needed to do. So I really think, and this is a state by state issue. I was in practice in Connecticut, and they put out some really strict rules as far as the number of pills that you could write and things like that. And so, as I said before, I moved from Connecticut, where I'd been for 33 years. I now live in Utah. I now have a Utah medical license, but I gave up my DEA certificate license because I don't really see, with what I'm doing with some clinic work and things like that, a need for me to write, narcotics.
That's awesome.
Are there some times? Yeah, but 2 to 3 days should, basically be it. I mean, if you've got somebody who's an MBA, multiple fractures, they probably need it. I'm not doing that kind of work right now.
Yeah.
So therefore, there really shouldn't be a need for me to be writing. So I think everybody is moving in that direction in the state of Connecticut. I've got a whole bunch of friends who are internists. Mm-hmm. They haven't written a narcotic prescription in years.
That's fantastic.
They say, look, if you need some narcotics for some sort of pain, I'm sending you to a pain management doctor. And I think, again, getting to this issue that you're referring to, is we need to, just like we're making diagnoses, we need to subdivide it. Is this an acute injury? Mm-hmm. But then with that acute injury, as we said, it starts with the physician's prescription. We've got to have a true limitation on how long you're doing that. And it kind of seems that there's very little reason for patients to be on long-term chronic opioid use.
Yeah, I do believe, I believe that one of the best ways that we can solve the opioid epidemic, at least from a medical profession, is by treating the root cause. If we're treating pain, there's going to be decreased reliance on pain meds, right? And I think that one of the things that happens is, I don't want to call it lazy medicine, but I think there is in part that of like, there's pressure from patients. They want to get out of pain, so you want to help them because there is a desire to actually say, like, I know you're in pain, I want to help you. But in the end, I do feel like a big part of the addiction on pain meds comes from the fact that they're terrified that they're going to be in pain. And I think that if you can truly treat at its root cause and you can make the pain go away, then it's a lot easier to deal with the addiction because you're not also dealing with the pain. And so I think as a profession, the better communication we have between multiple specialties and work together and find these procedures like you're talking about, the Intercept, that really do treat the pain really, really well, and you go to a pain doctor's office where they focus on treating the root cause, you're going to see that they rely less on pain meds because they're focused on fixing things. And I think that's really what our population needs. And I think that your solution is a big part of that. I think that if we can limit the overprescription of it, people have to rely on treating the root cause and can't fall back on saying, well, this seems to be working for you, so I don't want to change it, and we're just going to keep you on this, and then it slowly escalates until, they're maxed out on meds. Instead, it's, let's work to get you off of them, and the way we're going to get you off of them is by finding procedures like the Intercept that are going to treat pain at its cause, get you feeling better, and then we can get you off the pain meds and get you back to living a life pain-free. And I think that's really, really important as a community for us to focus on.
Well, and to your point, again, going back to our clinical studies, we talked about everything's got to be rooted in science, is we didn't have a lot of patients that were on narcotics in our clinical studies, but what we found was that in a short period of time, 30% of patients were able to decrease or give up their narcotics.
That's awesome.
But doing that is a partnership issue.
Yeah.
And part of it is, again, one of my big things, which you also talked about, is the why.
Yep.
Explaining to the patient, we're going to do this procedure, and afterwards, we know that you really should not need your narcotics any longer. So we're going to work on a weaning program for you for those narcotics. That has to be the comprehensive discussion. And to your point, all too often it just becomes a little bit too easy to just keep on sort of writing that low dose tramadol or whatever prescription, which again, we were told there was no tolerance with narcotics. Well, that turned out to be false, which is why it winds up escalating and requiring more narcotic use. So again, we really need to push forward.
One of the things that you've touched on a lot that I want to point out is the importance of provider teams creating the right expectations with patients, right? Whether it's pre-procedure of what type of relief they can expect, right? If you say, I know this is going to fix it, it's 100%. Well, if the patient gets 95%, which by any other measure would be amazing, they're going to be disappointed because you said it was going to be 100%, right? And you said under promise and over deliver, right? It's that expectation of we need to make sure that we're setting realistic expectations of outcomes. So that's one. But then the other part of it that I think is really important is expectations around how it's going to affect their life, right? Whether that says you're taking this much medication, I expect that if we do this properly and your pain goes down, you're no longer going to need these, and I'd like to start working you down from this after we do this procedure. If you set the expectation up front, it's a lot easier to have that conversation on the back end and start weaning them off. And so, how have you used expectations and setting expectations with patients to good effect as a doctor?
So that's really the key. I mean, you hit upon it. If I say, you're going to be perfect afterwards, and they're only 95%, Doc, you told me I was going to be perfect. So again, been one of my favorite lines forever: under promise and over deliver. And again, with these communication courses that I taught for many years, it's shared decision making. Mm-hmm. It's having the patient being a participant in the ultimate decision that's going to be done. And it's not the paternalistic aspect of the way it traditionally was. And you'll see, based upon the age of patients, you've got the patient who's 70 plus years old. Well, and you have the discussion with them and you go, well, Doc, you tell me what to do.
You just tell me what
and
to
it's
do.
like, no, we're going to have a discussion here. You've got to be an active participant in this. And so again, it's a age-related issue. I think, obviously because of internet searches and things like that, you have patients that are doing a lot of those online searches. And what I always said to patients, and we would talk about this in our communication workshops, say, how do you respond to the patient who comes in with 50 pages of stuff that they printed off from
Google,
the internet?
Yeah.
And I had one doctor go, I hate those. And I go, well, redirect it.
Yeah.
If you've got a patient who is interested enough in their condition to spend all this time searching, leverage that.
Yep.
Show them the sites to go to.
Yeah.
And it's like, there's a lot of garbage on the internet saying, hey, I really appreciate the fact that you've got such an interest that it must have taken you hours in order to do all this research. We don't need to get into the specifics of what you've had there, but let me give you the URLs of some really great sites that we rely upon as physicians, where we know that they're based upon great science and great research that's being done. Don't turn it down. Don't be dismissive, because you're just going to turn that patient off to what's going on. But one of the other things that's important, I think, is twofold. Is one, for every patient, more likely than not, they've got a significant other. And you've got to treat the patient, but also the significant
family,
other.
yeah.
You know, I get back to my wife going, look, for better or worse, I'm not loading and unloading that dishwasher forever. So again, what we've heard from patients and actually their spouses is, God, you gave me my spouse back, you gave me my significant other back. My quality of life is better because we can now go off and do things. The other thing, when we talked about a sort of a multidisciplinary approach, and some people, you know, shake their head when I'll mention it, but there's something out there called cognitive behavioral therapy. And, you know, people hear and they begin to, you know, put their hands to their head, and because they're really frustrated with it. And cognitive behavioral therapy, I think, has a role. It doesn't solve all problems. As I had a discussion with a medical director from an insurance company, it's really the rheostat. It helps to turn down the volume. So the patient who does have chronic pain, you have the ability to have them deep breathing, them understanding what their disease process is all about, knowing that, hey, this is not life-threatening and things like that. Because for a lot of these patients, it's really the fear of the unknown. So again, I think it's, you know, again, one of our tools is cognitive behavioral therapy. It doesn't solve the problem, as I discussed with a doc. He goes, well, cognitive behavioral therapy should help them, you know, eliminate their back pain. I go, no, it's not eliminating their back pain, but it takes it from a 7 to maybe a 5. I said, but I look at it as an analogy that if I have a rock in my shoe, cognitive behavioral therapy is not making that rock go away. I got to take my shoe off and get the rock out. And that's really what the Intercept procedure is doing. The Intercept procedure is removing that rock from your back. And then, if you've got other issues, cognitive behavioral therapy will potentially help you manage that, maybe help you get off your narcotics.
As far as, I love everything you said. I would always take a patient who is actively participating in their care, Googling and looking stuff up, than somebody who just expects you to solve it and they're not going to do anything, right? And so for people that have Googled and they've looked up stuff, I love that, because it's like, you care enough to put in effort. Therefore, put the effort into the right place and you're going to get better. And now if you can help them to see what the right way of treating with that, they're actively wanting to get better. How can you be upset when they're actively searching for answers? So if you can provide those answers and direct that energy, patient's going to get better. And I love to see that. So last question I have is, you know, great career that we've talked about that you've gone through, from, you know, actively treating patients as a surgeon, consulting, doing research and everything like that. What was the common passion and thread that kind of connects all the dots together?
So I think there are a couple. I think one is, somebody said that if you love what you're doing, it's not really work. And I think because I've had my own personal struggles, and I know how terrible and impactful those things were for me. It's part of the reason that I travel all over the country, meeting with different physicians, educating them on it, give them my cell phone number if they think they've got a patient indicated for this. I'll review films with them, because I kind of would like to be the Johnny Appleseed. Instead of spreading seeds and growing apple trees all over the country, spreading the word on what the Intercept procedure can do, because I know what it's done for me. I have posted early on after my procedure on my social media pages, and I've gotten emails or text messages or Facebook Messenger from people I went to high school with, people I went to medical school with, residency with, saying, hey, maybe this is my problem. And so I've got probably a dozen of those people who they send me their films, and sure enough, they've got the problems. I was just in San Antonio, and one of my former nurses retired and lives there with her husband. We got together, and she starts telling me, she had her hips replaced, but she's still having back problems. She sent me her MRIs, and she's got modic changes.
Yep.
And so because of the connections I have, I reached out to our local rep in San Antonio, and she's got an appointment with that person. And, she's looking forward to. So the common thread is trying to help as many people, and whether it was as a clinician, whether it was as a hospital administrator, as a consultant, it's all about trying to improve the quality of life, because is life really worth living if you don't have any quality of life?
Yeah, I think that's a great mission. I think certain people are called to go out and change lives and to help people, and it sounds like you're one of them. So thank you so much for coming and spending time with us, helping us to understand more about this, and in the end, like, sharing your story. It's an amazing story of what you've been through and how you've gotten relief from this, and we're grateful to have had you on today.
I'm happy to be here, and as somebody said, it's like one of those Hair Club for Men commercials. I liked it so much I went to work for the company.
That's wonderful. Well, thanks again, and we'll go ahead and end now.